Picture this. You wake up after a fainting spell, you log into the patient portal, and there it is. Syncope, likely vasovagal, no cardiac etiology identified. Then, later that week, you find a cardiology referral in the chart. What happened? Welcome. I'm Jess, a family nurse practitioner and legal nurse consultant. Over the next 20 minutes, I'll help you read those notes so you know what they mean and what to do next. Quick promise, you'll learn what parts of a note matter most, how to translate common shorthand, and exact words to use when you want clarification or a correction. Sound good?
Who writes these notes? Short answer, a team.
Nurses usually document vitals, intake, bedside changes. Nurse practitioners and physicians write the history, exam, assessment, and plan. Specialists add focused entries. Scribes or medical assistants may capture data too. So you'll see different wording depending on who wrote it. A quick bedside note versus a later diagnostic paragraph. That difference changes how a note reads, right? Here's a reading trick you can use immediately. Don't try to read everything. Want the short version? Scan 3 places first: the chief complaint, the assessment, and the plan. Those lines usually tell you the clinician's current thinking and the next steps. Want a tiny roadmap? The HPI is the story of why you came in. The ROS is a symptom checklist. The exam shows what they observed. The assessment is the working diagnosis, and the plan lists tests, meds, referrals, and follow-up. Okay, translation time. Some shorthand causes real worry, but it's often less dramatic than it sounds. If you see RO or rule out, that means the clinician is considering something and needs tests to confirm or exclude it. Not a final diagnosis, just a question mark that needs an answer. Words like likely, probable, or consistent with are working opinions. They're part of clinical thinking, not an absolute. Keep that in mind. And when you see non-contributory, it just means that section didn't add helpful information. Not dramatic, just neutral. Now, a few red flag phrases that deserve follow-up. If you read altered mental status without context, ask what behavior was observed and who reported it. That line alone is too vague to act on responsibly. If a note says non-compliant, pause. That's a judgment. Ask for specifics. Which instructions were missed and why? There are often good reasons worth documenting. See possible substance use. Request testing results or clarification before anyone assumes anything. Those phrases can affect future care and insurance decisions. Let me give you 2 anonymized examples so this feels real. Example 1, a clinic note reads, SOB x 2 days, tachypneic, CXR pending. Translation, shortness of breath for 2 days, fast breathing noted, chest x-ray not yet resulted, testing was in progress. Example 2, an ED note says, PE suspected, CTA ordered. That tells you the team was concerned about a pulmonary embolism and ordered a dedicated CT to check. Important next step, not an automatic diagnosis. Why does wording matter beyond curiosity? Because documentation drives downstream care. Referrals, prescriptions, and insurance coverage often hinge on what's written. Small differences change things. Atrial fibrillation chronic versus history of atrial fibrillation can influence monitoring, meds, or prior authorization decisions. Accuracy matters. So, how do you get your records and ask for corrections? Step 1. Contact the medical records department. Many systems let you request records online or with a signed form. HIPAA generally requires a response within 30 days, though systems can extend once for another 30 days, so note that timeline. Step 2. Ask for the specific visit or date range. Don't ask for the entire chart unless you need it. It's easier to focus on the notes that matter. Step 3. If something is wrong or unclear, request an amendment. Be specific. Name the note, quote the exact language, and explain the correct information.
Here are 2 short scripts you can use. Copy them exactly if you want. For clarification, hi, I'm requesting clarification on the note dated date. It states, quote phrase, could you explain what that meant and what tests supported it?
If they refuse an amendment, federal rules generally let them append your statement to the record. And if privacy is a concern, ask the health system's privacy officer for a review.
Before we finish, 3 clear takeaways, short and actionable. Takeaway 1, read the chief complaint, the assessment, and the plan first. That's your quick map.
Takeaway 2, flag phrases like rule out, non-compliant, and altered mental status for clarification. They need context, not assumptions. Takeaway 3, use the scripts I shared. Specific, factual requests work better than confrontational messages. Keep copies of your requests and responses. A quick privacy reminder. The examples I used today are anonymized and composite. If you suspect a privacy breach or potentially defamatory statements, escalate to the privacy officer and consider legal advice. But start with a clear request to medical records and your clinician.
If this episode helped, please subscribe to FAQ by Nurse Jessi for more myth-busting nursing guidance. Visit FAQ by NurseJessicaConsulting.com for sample scripts and resources you can use to access and correct your records.
Thank you for listening. I'm Jess, and if you need deeper help interpreting a chart for a legal or clinical case, you can learn more at FAQ by NurseJessConsulting.com. Until next time, stay informed, stay compassionate, and always put safety first.